pues como 25, 30 aspirantes. El examen fue como de 50 preguntas. Nos preguntaron mucho de las curvas de presión, algunos de pulsos, de las ondas A, ondas X, ondas B. Estuvo bien el examen, y la entrevista pues también fue después del examen para algunos y otros al otro día, y pues nos preguntaban lo básico, que para qué queríamos ingresar ahí, que cuál era el motivo, si teníamos el recurso económico, y pues nada más. Y el examen de Monterrey, ese examen sí estuvo un poco más pesado. Fueron como 150 preguntas, y sí venía mucho de hemodinamia. Y también fuimos como 30 más o menos.
En la 34, Milito.
Sí, también.
Ok, bueno, muy bien. Perfecto. No, pues de rato o más tarde platicamos. El plan es de que en esta semana, en este mes, acuérdense, estamos viendo miocardiopatías. La semana pasada, empezó Eric con así todo lo del capítulo del Brandwell. Luego el martes revisamos algo de lo que se presentó en el Congreso Europeo, y después el jueves presentó Miguel Galicia un artículo que lo revisó el doctor Leiva. El doctor Leiva va a estar esta semana por lo menos en casa, dio positivo para COVID y anda con muchos síntomas. Entonces, bueno, pues va a estar, no va a estar, pero de rato hablo con él para ver si mañana puede estar con ustedes en la revisión, porque mañana a la una hacen la evaluación del programa de PNPC de CONACYT. Parte importante para para mantener el nivel. Vamos a aspirar para un nivel más alto. No sé quién nos vaya a evaluar o quién, pero bueno, pues entonces le voy a pedir que alguien prepare un artículo, y le digo al doctor Leiva que ahora que va a estar ahí encerradito, pues que si nos ayude a revisar ese artículo. ¿Ok? El plan de hoy es de que vamos a continuar con lo presentado en el Congreso Europeo. Vamos a poner aquí, voy a transmitirles otra parte ahora acerca de miocardiopatías. Y después haremos algún ejercicio. Ya está el programa ahí en el chat. Después seguiríamos con miocarditis, lunes y miércoles. Pero encontré aquí también muchos casos clínicos interesantes que podremos utilizar para enseñanza acerca de miocardiopatías. Entonces voy a empezar a compartir la pantalla. Ahí voy.
Hello, my name is Nuno Cardim from Lisbon, Portugal, and I'm the host of this session, Meet the Expert, Comprehensive Risk Prediction in Cardiomyopathies, Imaging, Pathology, and Genetics. I would like to welcome the audience and also to welcome our faculty, Professor Luís Lopes from London, UK, Professor Bjarke Jensen from Amsterdam, Netherlands, and our discussion, Professor Cristina Basso from Padova, Italy. So let's go to the first case. Professor Luís Lopes is going to present it. The thickened heart. Luís.
Thank you. First of all, I would like to start by thanking the invitation to be here and share this case, focusing on the comprehensive risk assessment in the thick heart. I have no conflicts of interest to declare. This case is regarding a 30-year-old male presenting back in 2011 with an episode of peripheral embolism in the right popliteal artery, treated with fibrinolysis at the time, and preceded 2 weeks before by a viral-like illness. He was started on treatment with warfarin, and biventricular hypertrophy and pericardial effusion were noted on his echo. He was then referred to our center for further investigations. Just to give a brief overview of his symptoms throughout time, 1 year more or less after presentation, he started having reduced exercise capacity and was in New York Association class 2. He had one presyncopal episode and started having some occasional chest pain. 1 year after that, he had more frequent palpitations, some lightheadedness episodes, and was admitted due to a first episode of chest pain with mild troponin elevation. Then for the next 7 years, he stayed in New York Heart Association class 2 with no syncopal episodes, but with 2 further episodes of chest pain with myocarditis-like presentation. His past medical history was largely unremarkable, but included the murmur detected as a child, irritable bowel syndrome diagnosed at 22. He was a known smoker and didn't have any alcohol intake. He was medicated throughout with warfarin, bisoprolol in varying dosages throughout time, and buscopan for his irritable bowel syndrome. On the physical examination, he had a mid-systolic murmur, soft with no changes with Valsalva, a displaced cardiac impulse, otherwise unremarkable from the cardiovascular point of view, with no signs of fluid overload, and also with no relevant extracardiac findings, including cutaneous or otherwise. His family history, again, mostly unremarkable, with the possible important exception of 2 cousins from his paternal side of the family, where 2 heart attacks were mentioned, although we never had further detail about this. His younger, older brother and 2 parents all live abroad, like the rest of the family, and unfortunately never wanted to engage in clinical or genetic screening. So moving on to his, ECG, which throughout showed sinus rhythm with normal axis, some non-specific interventricular conduction abnormality, inverted T waves in the left precordial leads and the lateral leads, with overall more or less normal voltages. His cardiac imaging here on the panel on the right, showing on the left some echo images, and on the right MRI images seen as from top to bottom, a 4-chamber, 3-chamber, and a mid-short axis slice. But overall, the cardiac imaging showing severe LVH, left ventricular hypertrophy, with almost 3 centimeters of maximal thickness, incomplete caudal SAM, but no LVOT gradients of significance at rest or provocation, a good radial function, but impaired longitudinal function, moderate diastolic dysfunction with increased left ventricular filling pressures, a moderate pericardial effusion with no hemodynamic compromise, but also RV free wall hypertrophy, which is visible in the MRI, but also on the echo image. The tissue characterization on MRI showed a striking, very severe, massive scar, LGE, shown here in 4-chamber, 2-chamber, and mid-short axis slice, involving huge percentage of the myocardium, mostly mid-wall, but also with regions of transmural scar. Interestingly, his early GAD images also shown some MVO-like images with hypointensity, here shown in the septum and the lateral wall. And matching the areas of LG in particular, he had high signal intensity on T2 weighted images. Here shown are 2 mapping images of 2-chamber and mid-short axis slide, with the more increased areas on T2 shown as these bright orange spots, as shown here in the inferior wall and also in the insertion points of the RV in the septum, with values that were around 70 milliseconds. And also on the more classical STIR image, also T2 weighted, he had these bright spots near the RV insertion points. T1 mapping values were also elevated. His Holter was similar throughout follow-up, showing always sinus rhythm with some PR prolongation at night, around 500 polymorphic VEs with no other arrhythmias noted. His blood tests were particularly remarkable for a continuously mild troponin elevation throughout follow-up, but otherwise with normal FBC, normal renal function, normal inflammatory markers, virological and autoimmune screening being negative, thrombophilia screening negative, and normal alpha-glucosidase activity. He had also had a normal coronary angiogram even before referral to our center, and his cardiopulmonary exercise tests here with examples from one of them showing around 50 to 60% VO2 max and normal blood pressure response. So after these first few investigations, months after his referral to our center, the discussion revolved around etiology, HCM versus phenocopies, or a possible component of a dual pathology with inflammatory cardiomyopathy as part of the discussion. And this all due to his biventricular hypertrophy with a very unusual and very extensive scar, but also these myocarditis-like presentations together with edema on imaging and his troponin elevation. As part of the discussion, his rhythmic risk was also discussed in consideration for an ICD. And at the point in 2012, he had no classic risk factors for sudden cardiac death. The decision was hence to optimize his etiology, but also risk assessment to perform an endomyocardial biopsy, which I share here some images for the right ventricular biopsy, which showed hypertrophy and not much disarray, hypertrophy of the cardiomyocytes, mild interstitial fibrosis, all in keeping with sarcomere HCM. Then after yet another myocarditis-like presentation with chest pain, troponin elevation, he was submitted to this FDG PET, which showed this striking marked increased uptake along the LV and RV walls, with otherwise no significant avid lymphadenopathy, lung lesions, or otherwise any other FDG avid lesions. Due to these results, he was rediscussed, and the decision was made to perform a left ventricular endomyocardial biopsy, which again I show and share the images here, largely very similar to the right ventricular one, with more fibrosis demonstrated, but importantly, no features of inflammation, no inflammatory infiltrates, no features of storage, metabolic diseases, or any HCM phenocopies. This was complemented by electron microscopy, again with the same findings. At the same time, he was, for the first time, sequenced in 2013 with a relatively large panel of around 20 genes, and 2 variants were found in beta-myosin heavy chain, one clearly pathogenic and one variant of unknown significance. The classification according to the American College of Medical Genetics is shown in the right side of the slide. And then importantly, in 2017, and still due to doubts in terms of the genetic background of this severe presentation, he was also enrolled in a whole exome sequencing project, and no candidate variants were found in other genes, including phenocopies, metabolic, or other possible genetic etiologies for his left ventricular hypertrophy. So in terms of discussion for sudden cardiac death risk, in summary, he had no classic risk factors, but a very extensive scar, although with normal radial function, but with an impaired longitudinal function, a possible component of what could be inflammation on imaging, but not proven histologically. His ESC score, if we calculate around 2014-15, was 3.87% at 5 years, so formally at a low risk category. But he was discussed, and due to the severity of the phenotype, decided to be referred to an subcutaneous ICD for primary prevention with no therapies delivered throughout follow-up. So some points for discussion around the possible refinement of the phenotype and etiology, starting with an initial diagnosis on the first hospital he was admitted, thought to be myocarditis as an explanation even for the hypertrophy, complicated at the time by an embolic event. Thrombophilia screening negative with many years of follow-up and repeated tests by hematology, autoimmune screen negative, but recurrent, what was called myocarditis-like episodes with edema on MRI, positive PET and continuous mild troponin elevation. Despite all of this, he had histological findings compatible with sarcomere HCM and also genetic testing compatible with sarcomere with at least one pathogenic beta-myosin heavy chain mutation. So some questions that I would like to leave to conclude are about the possibility of a dual pathology here. If we can speak about possibly an inflammatory HCM or HCM with hot phases, including inflammation or other possible explanation for these findings, and what are the implications of all this for risk assessment. Thank you very much.
Thank you, Luis. It's a very interesting and complex case, very challenging also. So I will pass the stage to Cristina to start the discussion.
Thank you, Nuno, and thank you, Luis. I mean, this presentation is quite amazing because this is a strange case with a very extensive late announcement, late gadolinium announcement, and myocarditis-like presentation. When we say myocarditis-like presentation, it's chest pain, edema, and troponin release. So you call exactly these hot phases of hypertrophic cardiomyopathy like we are used to call hot phases in arrhythmogenic cardiomyopathy. In arrhythmogenic cardiomyopathy, there is evidence that they are inflammatory in origin. In hypertrophic cardiomyopathy, the debate is whether these PUSE or these myocarditis-like presentation are mostly ischemic versus inflammatory. So, which is the clinical workup, diagnostic workup to differentiate ischemia versus inflammation in these patients in hypertrophic cardiomyopathy?
Sure. So we certainly perform more often as part of the imaging assessment, and particularly on the MRI, currently perfusion sequences as well. So stress MRI, particularly if the patient, like this gentleman, had various episodes of chest pain. So we already knew from the start, because he was submitted in the local hospital to an angiogram, that he didn't have coronary disease. But we know that small vessel microcirculatory disease can be a very important component of the pathophysiology of HCM. In terms of possible evidence, I can add, I didn't add to not overwhelm the slide too much, but he did have perfusion on the second MRI before the ICD was implanted. And actually, we didn't find a perfusion defect, which came as a little bit of a surprise given all the florid case. But we certainly have very important perfusion defects and have just recently published in Heart a paper about this theme. And I agree. I think that for probably most of the HCM patients with these recurrent chest pain episodes, and particularly with the ones without obstruction, certainly ischemia caused by small vessel disease has a very important role. And we do have proof for that, including non-invasive imaging. The question is still if what is the role of that ischemia or the possible impact as well in terms of risk assessment. And this is work that we have some evidence for a worse prognosis, but in terms of independent value, like other features of this complex disease, is still to be clarified. Certainly this patient didn't have, as much as we've searched for it, any evidence of inflammation in terms of histology. So I think a good possibility, even if we didn't find it in one MRI, is indeed ischemia.
Yeah, of course, the myocardial biopsy, repeated, by the way, 2 times, first in the right ventricle and then in the left ventricle, is showing a lot of fibrosis, particularly the left ventricular one, Unfortunately, there is no evidence of a small vessel to judge small vessels disease, but is excluding by sure inflammation in this patient, at least in this stage when the patient had the biopsy. So in terms of cardiomagnetic resonance, the edema you are describing by cardiomagnetic resonance theoretically could be in keeping with both an ischemic origin and a myocarditis origin, because the edema is the same. So this kind of sequence in cardiomagnetic MR is not able to distinguish ischemic versus inflammatory. You understand my question?
Absolutely.
Origin of edema.
Yeah, I agree. So both of them, as we know from proper ischemic disease, both could be possible explanations of these regions of edema for sure. And then we have the PET scan though, which supposedly could be a pointer for inflammation. But then the challenge there is that we also know that the myocardium in HCM is changed from the metabolic point of view in a way that sometimes it can give us high positive findings on the PET scan. Maybe not as striking as in these patients, which with good preparation was quite striking, but we do have positive PETs just because of the metabolic changes that are part of the HCM pathophysiology.
Good, and of course this patient had a beta-myosin heavy chain mutation, and you showed a big family, but unfortunately this big family, if I well understand, was not available to come for either cardiological or genetic screening. So what is the added value, which is the added value of this genetic information in this patient? I don't think that we need the genetic finding to end up with hypertrophic cardiomyopathy diagnosis. Probably if you have some doubt, okay, but in this case, the degree of hypertrophy, all the other tests were eventually in keeping with hypertrophic cardiomyopathy. So in terms also of recommendation, if you have just a single case and not the family available, are you going to perform as well genetic testing in your clinical practice, or what is your suggestion, recommendation?
I think in general, that's thank you for another great question. So I think for in general terms, we do reserve genetic testing for the benefit of the family, with particular cases and challenging cases like this one, where the diagnosis is not sorted in terms of the finer cause or etiology. Genetic testing has a very important role there. And that's the reason why we even expanded for whole exome sequencing. So one of the unsolved questions here is if the beta-myosin heavy chain variants, the pathogenic and the variant of non-significance, for example, are in compound heterozygosity or in the same allele. And because we didn't sequence the parents, we don't know that, and might have been an interesting thing to know, because it might eventually justify the severity of the phenotype in itself. And definitely the screening of other genes related to metabolic, storage disease, and so on, phenocopies in general, to use a more global term, I think was important to exclude together with the histology to reach a final diagnosis, apparently, of sarcomere-only hypertrophic cardiomyopathy in this patient. So aside from the family value, I do think genetic testing in cases like this also has a very important diagnostic value in itself, which can then lead to different options of management of the patient, and even different perceptions in terms of risk, which could be quite different between sarcomere and other differential diagnoses of left ventricular hypertrophy.
Thank you, Luis. I have just 1 minute question, because we are running out of time. We could spend about more 1 hour discussing this case, because there are so many points. Can you please comment on the ICD implantation indication? Because according to the SC score, it's a low-risk patient.
Mm-hmm. So, well, basically the 1 second answer is SCAR. Here, I think it's one of those cases where we have to go a little bit beyond the formality. Even at in the first discussion, if we list the classic risk factors, he also wouldn't have any of those classic risk factors. I think the severity of hypertrophy, and together with the extensive scar, still whatever the etiology for them is, this type of hot phases, all of that together led to a perception of an increased risk and the decision to the implementation of the device.
Okay, thank you so much, Luis. Now it's time to move to the second case. Professor Bjarke Jensen from Amsterdam, Netherlands.
Bueno, ¿qué les pareció el caso? Miguelito, Ricardo, muy interesante, ¿no? O sea, a ver, ustedes algún comentario que quieran hacer acerca del caso que presentó el doctor Rocha. R3, ahí están.
Sí, doctor, nada más que no se escuchó lo primero que dijo.
Les decía que si tienen algún comentario acerca de este caso.
Pues
R3.
es un caso muy raro, ¿no?
Miguel. Ajá.
Oye, bueno, lo que iba a decir es que un caso muy raro, ¿no? Una mutación de novo y la presentación como no fue habitual, que inicialmente parecía ser más algo inflamatorio y hasta que llevaron a cabo los estudios de imagen que realmente están complicado tenerlos, por ejemplo, aquí en nosotros a nuestro alcance, pero que finalmente incluso tuvieron que llegar hasta la realización de la biopsia endomiocárdica para diferenciar y poder encontrar cómo no se trataba de un patrón de inflamación propiamente, sino más bien de hipertrofia. Y el gen que ponen ahí, el MYH7 me parece que es el 7 y el 9 los más comunes en el caso de las mutaciones aisladas.
Ok, ajá. Sí, Miguel. Ricardo.
Sí, sí es el más común para este tipo de patologías, y que sea de nuevo, pues también es muy, muy, muy raro. El caso de la biopsia, pues ya lo hemos comentado, ¿no? Entonces, en este caso, pues es, digamos, uno de los representativos en el cual sí nos ayuda o nos apoya a establecer bien el diagnóstico, y sí estaba bien indicada, que ya hemos visto cuáles son las indicaciones. No todos los pacientes tienen que llegar a biopsia por la rentabilidad diagnóstica. En ocasiones no nos va a hacer gran diferencia. Este es uno de los casos en el cual sí. Y pues ya al final lo que comentó, bueno, no lo entendí muy bien, le preguntó acerca de la indicación del DAI. Entonces, ahí sí no entendí muy bien cuál fue el punto al que llegó, pero es también un punto a considerar dentro del tratamiento del paciente.
Miguel Reyes o Poncho, ¿algún comentario? ¿Sí me escucharon? Miguelito o Poncho.
Perdón, doctora, aquí está, nada más que se traba un poquito el audio.
Ok. Bueno, al final creo que uno
Perdón, porque es que estoy en el cine viendo una paciente.
Estás teniendo un bebé, Poncho, ¿qué dijiste? Estás viendo la paciente.
Gracias. No,
Okay.
Hablaron que la mandaron de urgencia del niño y la mujer, parece una sella.
Ok. Sí, está bien, Poncho. Sí, creo que acerca del desfibrilador, si ven, por ejemplo, uno de los artículos que revisamos de Miguel Galicia era la utilización de las escalas de riesgo, la escala de riesgo, la validación o puesta en práctica de una de una escala de riesgo para pacientes posinfarto con FEBI baja. Sin embargo, obviamente, pues como no vemos todos los días miocardiopatías hipertróficas, aquí lo que hicieron fue utilizar una calculadora de riesgo, ¿no?, de la Sociedad Europea de Cardiología para pacientes con miocardiopatía hipertrófica. Les dio un puntaje bajo. Sin embargo, lo que le preguntan es, y aún así, ¿por qué le opción el desfibrilador, no? Porque después de 6 años de evolución con el desfibrilador no había dado ninguna descarga. Y lo que dijo el doctor de Portugal, el doctor Rocha, es de que fue basado en la cantidad de cicatriz que tiene en el miocardio, ¿no? Alrededor del 60% del total de la masa ventricular es un tejido cicatricial. Entonces, creo que fue lo que los puso, y si bien en todos los casos hay que tratar de utilizar esas calculadoras de riesgo, pues cada caso es diferente, ¿no? La otra cosa interesante es lo que contaba Miguel Galicia, ¿no? Es un caso que se pueden presentar así, o sea, pacientes que tienen miocardiopatía hipertrófica y que se nos presentan con episodios de dolor precordial agudo, liberación de troponinas, cambios eléctricos, y ahí es muy difícil, es tanta la hipertrofia que bueno, si bien sí pueden tener enfermedad arterial coronaria, habitualmente no la tienen, son pacientes de edades cortas o no tan avanzadas. Hay que descartarlo, como hicieron ellos con un angiograma, ¿no? Pero les quedaba ya entonces el diagnóstico diferencial entre isquemia por el problema entre el aporte y la demanda, ¿no? O sea, la demanda es tanta de los cardiomiocitos, tanta hipertrofia, que obviamente hacen fenómeno de isquemia, sin que necesariamente haya enfermedad arterial coronaria. Pero lo que les marcaba a ellos mucho eran los patrones de inflamación del edema, ¿no? En la resonancia magnética. Y por eso estaban tratando de dilucidar si estaban ante un caso de hipertrofia, miocardiopatía hipertrófica biventricular, con miocarditis like, caso, o sea, episodios de miocarditis like. Pero bueno, que era en lo que se centraba también la doctora de Italia, ¿no? O sea, pero bueno, pues sí, no, muy interesante caso, ¿no? Y las imágenes, pues, muy impresionantes. Ok, ¿algo más que comentar? Eric, ¿ahí estás, Eric? ¿No? ¿Todo dormido?
Sí,
Ahí está,
doctor.
Eric. ¿Qué te pareció?
Pues es igual un caso interesante, como se comentó, una mutación de novo, aunque pues realmente el papel, pues, de la biopsia mecánica, pues, fue fundamental para el diagnóstico, aunque realmente, pues, no en todos los casos se hace. Siempre los estudios de imagen, pues, siempre tienen hallazgos ahí importantes que sí nos hacen pensar. Y pues, pues nada más, que pues sí es un caso muy interesante.
Ok, muy bien, Eric. Bueno, vamos a, ya son 7:40, aquí le detenemos para está de guardia, ¿quién está saliendo? ¿Quién entra?
Yo me quedo, doctor, de guardia, sale Ponce.
Ah, bueno, perfecto. Entonces ahorita nos vemos en el hospital. Les pido, Ricardo, si puedes preparar un artículo, o Miguelito Reyes, ¿sí? Para mañana, por favor, y ponerlo en el chat, y yo hablo con el doctor Leiva, para ver si él puede estar en eso de la revisión de ese artículo. ¿Qué más debe de haber hoy? A lo mejor por ahí algún eco, algún paciente citado. Yo tengo reunión a las 10 ahí con el doctor Magaña, todas virtuales. Luego a las 11 tengo lo de instrucción clínica, y a las 12 tengo lo del comité de investigación de los protocolos. Okay. Pero bueno,
Sí.
ahorita pasamos. ¿Hay pacientes en la terapia, jóvenes?
Sí, doctor.
Ah, el paciente que llegó, ¿verdad? Del infarto.
Sí.
¿Y doña Bundia colgó los tenis o qué?
Como digo que se fue de alta voluntaria, por ejemplo.
Ok.
Sí, doctor, se fue de alta voluntaria ayer como eso de las 8 de la mañana. Se habló con los familiares. La verdad es que En Ucrin tuve todavía más deterioro respiratorio y ofrecieron medicina interna e intubación, no quisieron y prefirieron mejor llevarse a la casa.
Bueno, ok, está bien, sale, entonces nos vemos con unos 30 minutos ahí en el hospital.
Ok, doctor.
Órale,
Gracias.
gracias, bye.